Hello and welcome to another Piper Pearl. Today this Pearl is going to be focusing on the clinical consultation skills that you can use in any environment when providing or investigating patients' needs. So we're going to go through the general premise of consultation and offer a few tips, a few things to think about in your own practice in order to improve the relationship between yourself and the patients that you're caring for. So starting off, a good thing to think about is when we talk about consultation skills, we're really looking at that primary healthcare space. So in the primary healthcare space, it's the role to start an investigation and to basically create an arrangement between you and the patient in their care. So a lot of clinicians fall into the trap that you tell patients what to do, therefore they must comply. But a lot of the times, it has way better outcomes if you can actually form a relationship. And it's that forming a relationship that is very difficult to educate and can be very difficult to achieve as well. So on top of the general clinical skills that you will need, you'll have to know what you're talking about. You often will need time management skills. You don't really have the time to spend 1.5 hours talking to a patient, so that definitely has to play a part. Things like communication skills and counselling skills are essentially the most important skills you can have when interacting with humans, but they're also the most difficult thing to teach and definitely the most difficult art to master for many people. Some people have the gift of the gab, they're very interpersonal, but it doesn't often come natural to others. When we look at our diagnostic skills, this is an art form that is dying. And across literature, it's well publicised that the diagnostic skill that used to be available in the absence of technology is a dying art. Now, it's no fault of clinicians that this is the case because we have much more sensitive tools that we can use these days compared to the past. But if you find yourself in an environment where you don't have the benefit of technology, and diagnostic skills can be your main weapon in your arsenal. A big role that we play in a patient's life is that education. So there's a big difference between education and dictation. So education implies that there's a level of agreement and understanding from the patient. So don't talk at a patient, educate the patient in what you believe their needs are and work with the patient, even if they disagree with you at the time. So when we break down primary healthcare, there's a series of different modes that people will come and visit us for. Now, this is environmentally agnostic. It doesn't matter where you are. Patients will come and present themselves to the first point of call, which in our case is often the medics, in order to seek some sort of help. So the main thing people do is they come with a problem. So they have a problem, they need help fixing it, they come and see us, whether they need access to pharmaceuticals or a referral, or they don't even know what's going on, they will come and see us first. The other thing that people can do with a modal consultation, or an advantage that you can take, if you will, is you can aim to modify the health-seeking behaviours of the individual. Now this is twofold. There's the people that will come see us for everything, even if they don't need to, even if they're more than capable of taking care of it themselves, and clog up the system and take time from other people that may need it. And then there's the other end of the spectrum where people, due to stoicism, due to their own personality, they don't want to bother people, they will not seek help until they absolutely have to. Unfortunately, at that stage, it's a lot more difficult to manage. So the modification of health-seeking behaviour can be to encourage the individual, let them know that had they come sooner, the outcomes would probably be better. People will revisit us with continuing problems in their management of chronic conditions, things like that, but there's always an opportunity for health promotion. It's a fine line between always over-providing health advice, considering the magnitude of advice that is out there and the variables of human preference, but you should always take the opportunity to provide that education and that health promotion whenever you can. Okay, looking into the actual consultation now, there's really 3 primary phases of every single consultation, and it starts, I should say, with the most difficult of all, which is establishing that rapport. And then we move into that diagnostic phase, which is really that investigative phase where we get all the subjective data, we do our objective tests, we formulate some sort of an assessment, and then we move on to the management phase, which really is taken care of by the plan. And the plan always includes education, explanation, you don't just treat. Obviously, the treatment, and then we have the concept in our world of restrictions to service, to employment, things like that, and any referral that needs to happen. So we're just going to take a little bit of time exploring tips and tricks that you can employ in each one of these phases to aid in the consultation. So starting with the most difficult is establishing rapport and empathy. Now, unless you are a very good actor, people find it difficult to fake rapport and empathy. So if you find yourself having to force or fake empathy, most of the time, you're not going to be successful. So the idea is you're going to have to try to find a way to establish rapport or establish empathy in one way or another. A lot of the time in the health centre and the health world, clinicians get the opinion that patients are a burden. Okay, so they forget their role, they forget why they're employed and what they need to do, and they automatically see patients as a burden, as in, why are you presenting to me? Why are you interrupting me? You're just seeking drugs, you're just seeking the day off. So try to have the mindset or establish the mindset of giving people the benefit of the doubt. Okay, so there are going to be people that are purely there trying to work the system. Okay, and you can't change that. Doesn't matter what you do, that is going to be the reality. But everybody else shouldn't suffer because that reality exists. So you should establish the mindset of giving people the benefit of the doubt, and your role is to treat them. Now, you may not like this person, you may not like who they are, you may not like why they're presenting, you may not like their personality. But always remember that professionalism and your obligation in your role doesn't actually care about your personal feelings towards that person. So if you have strong political or social views, fine, you're allowed to have them, but keep them out of the workplace and don't let it interfere with the rapport that you establish. When you're consulting, it can be difficult, but think about your physical position and how you would feel on the receiving end. A lot of the time, if you're standing up over the top of someone, it's very difficult to establish a rapport. The sitting behind a desk can also be a barrier of establishing a rapport. And I know it's not really fair because that's the way a lot of our clinics are set up, is this way. But try to sit down on a personal level and have more of an investigative or an inquisitive conversation with the individual, as opposed to taking turns of rebutting one another. Now, it's not easy, it's not comfortable, it does take practice, but challenge yourself. Challenge yourself establishing rapport with people you generally wouldn't talk to if you were given a choice. Once the rapport is established, the diagnostic phase is a lot easier. People are more willing to share, more willing to give the inner workings of their condition, their mindset, if you have that established rapport. If they trust you and they believe that you're there to help them, they're more willing to engage. So always let them give their story first. Okay, ask them, why have they presented? How can you help them? What can you do for them? Always start with their story. Once you hear their story, you start with your subjective investigation. Now, people often recommend ample or sample. Okay, it's got a lot of publicity. It's well out there. Most people know it. I personally don't like it. And I'm going to do a lesson on my version, which is EPSAM, in order to give alternatives to the age-old ample, if you choose. Certainly not a mandate, but we'll go through that in a different lesson. Now, always consider the possibility that there may be an underlying reason for the person attending. And some people are not willing to give this reason due to guilt, due to not feeling comfortable with you, pride, whatever it is, until you fish or establish that rapport. So always consider that there may be ulterior motives to the person attending. Once you've heard their story and you've gone through your story and there's a whole bunch of series of questions throwing around, talk with the patient, let them know what you're thinking. You do this for two reasons. One, it summarizes it in your head, but it also provides the patient with the information they need before moving on to your physical examination. And often the patient will correct you or provide additional information that wasn't provided in order to reshape the way you were thinking. Okay, so it can be beneficial for both parties just to summarize where you're thinking after this subjective data has been obtained. When you move away from your subjective data, you can move straight into the physical and the exploratory phase. Now, most of the time, your objective findings can be isolated to just your subjective hypothesis. So what you're thinking based on all the information you've been provided. But be aware, because we live in a world that is based on guidelines and protocols, if you choose to deviate away from what is considered to be a clinical standard, you need to always mention pertinent negatives that you didn't do a test or you didn't progress down a route. So then it shows that you thought about the standard, you thought about what was needed, but because of whatever reason, you chose not to do it. Okay? Always be aware of your own bias. It's very easy to get an idea in your head and then run with it, so still consider the possibilities in your examination of other things. Before you go on with a physical examination, you must obtain consent. We're dealing in the primary healthcare state. They're not unconscious anymore. Consent is not applied by them walking into the room. They've consented to seeing you. That's it. So if you're going to do any investigation, explain what you're going to do and get consent. Because we're in the position where referral is possible for us to higher care, it always is, always question whether or not the investigation you're doing is necessary. Or are you just doing it because you've read about it and you think it's cool? Okay? Clinicians fall into the trap of doing the cool tests when they're not really necessary. I think a classic example of this is McBurney's point or McMurray's point, where you're basically trying to find some rebound tenderness that puts the patient through pretty significant pain, even though you know full well that you're going to do it, the next nurse is going to do it, the doctor's going to do it, everyone else in the town's going to do it, and all of a sudden the patient's had the same test done 7 times, just putting them in more and more discomfort. So if you need to do an investigation because you're the only one around, absolutely do it. Don't hold back. But if you're doing it purely because you think you need to or you think it's cool, maybe just question whether or not it's in the patient's best interest as opposed to feeding your curiosity. Once the diagnostic phase is done, we move into the management phase. So this is where you do your assessment before you're moving on to your plan. So explain your assessment for the same reason we spoke about, summarizing your subjective data. Provide that patient education. And this education transcends across the entire management phase, which you talk about the problem, you talk about prevention, the management, any restrictions you're putting on, and then good medication education as well. When you're coming up with a treatment plan, don't be afraid to consider a treatment plan in the immediate, the long-term, and the future prevention of themselves or other people from getting sick. And you can write out all 3 in that way. The immediate plan is this, the long-term plan is this, when they have to come back, that sort of thing, if things change, that sort of stuff, and then prevention. If you're providing medication, then you must provide education. There's no such thing as providing medication in the absence of any education. Okay, so just keep that mindset. You can either dispense it yourself or you can write a recommendation depending on where you're working and what your scope of practice is. Now, if you're in the military, restrictions are a big part. We restrict people from physical activities, we restrict people from work. It should be in the interest of keeping the patient safe and basically preventing further harm. But try to keep your restrictions in the same line as the restrictions are written in the policies, the 1/2, the 2/4s, things like that. Don't just make restrictions up. And if you are going to give restrictions, always consider whether or not it's going to be helpful for the patient, as in, is your restriction going to stop them completely from completing a course, or going to stop them completely from working when they actually want to work, they're passionate about working, they've got things to do. Is your restrictions going to hinder the patient further? And always consider the restrictions that you're writing as a means of educating the chain of command. The chain of command is reading the restrictions and they have no idea what you're talking about, and the restrictions aren't helpful. Okay, so restrictions are often done poorly, they get blanket out there, and the patient can just say what they want. Try to have it as a negotiation phase. Patient's best interest in safety, but obviously don't stop them from progressing or working, things like that. It's more of a balancing act, really. And then consider your referral to higher care, referral to further investigations, whatever it may be. It all forms part of the management phase. Okay, so that's the end of the Pearl, talking about the consultation skills and phases that you will go through. It's one of those things that's notoriously difficult to teach. You will practice it in classes, you will practice it in CTRs all the time, but it's not really until you start challenging yourself in having those difficult conversations or having those investigative conversations with a patient, forming that relationship and having more of a mutual understanding on a treatment plan, that you'll really get the idea and the essence of what a true consultation is. So by all means, go out there, practice these skills, do good consultations with patients, make them feel part of the investigation, part of the treatment plan, and your clinical skills will improve. But until next time, take care.